Hey, BC here for BCNephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, kidney transplant, immunosuppression. Some important things to know about the drugs. First of all, the calcineurin inhibitors. Tacrolimus is most commonly used. This had traditionally come in a short-acting formulation that's dosed Q12 hours. Either can be a capsule or a liquid formulation. More recently, there are extended release formulations, both a capsule and a tablet. The extended release formulation that's most commonly used is the tablet and goes by the name of Envarsus, sometimes called Tacrolimus XR. The thing to know about this, there is not one-to-one dosing. The extended release formulation is typically about 20% lower than the total daily dose of the short-acting formulation. So therefore, if someone was on Tacrolimus 5 milligrams in the morning, 5 milligrams in the evening, total 10 milligrams of the day, the starting Envarsus dose would be 8 milligrams. The other thing to know about tacrolimus is, as it is the most important immunosuppression, it typically should not be held. The only reason it would be held is if there was toxic drug levels, and therefore, even if a patient is MPO, it needs to be given. The intravenous formulation is very rarely used. It is difficult to administer and can be associated with significant nephro and neurotoxicity. Therefore, it is much preferred to give enterally. If the patient's MPO, this can be given down a feeding tube. If for some reason this is not possible, the contents of the short-acting capsule can be given sublingually, and this is absorbed into the system. Some, but not all, advocate for a 50% dose reduction if you're using the contents of the capsule sublingually. In either case, levels should be monitored and the dose is adjusted. Tacrolimus is a drug where levels are monitored. These are typically trough levels before the morning dose of either the short-acting 12-hour or the extended-release 24-hour formulation. Another thing to be aware of, if you see a level that doesn't make sense, really make sure that the timing of the dose, that it was a true trough before making changes. There are a number of drugs that interfere, both raise and lower levels. Some of the ones to be aware of are macrolide antibiotics, which can raise the levels, azole antifungals, which can also raise the levels, and some HIV meds can raise the levels as well. Some of the drugs that can lower the levels are some anti-TB medications and anti-seizure medications. So when using any of these medications, be careful and monitor the levels closely. Be in communication with the transplant provider to see if dose adjustments should be made proactively. Some of the side effects to be aware of is that calcineurin inhibitors can cause nephrotoxicity. If the levels are toxic, there can be acute kidney injury. There can be associated with chronic nephrotoxicity as well. And acute high levels can cause neurotoxicity, with tacrolimus most commonly tremors. For a more comprehensive list of drug interactions and side effects, check out the article at BCNephro.com. I'll put a link to that in the description below. Now moving on to the antimetabolites, mycophenolate. The side effects of this, in addition to suppressing the immune system and increased risk of infection, include leukopenia and GI intolerance, specifically diarrhea. This is a medication that can be held if there is a severe acute infection, leukopenia, or other contraindication. It is sometimes a drug that will be held if the patient is thought to be too immunosuppressed. Either they have a malignancy, they're frail, they have something like CMV disease. This drug may be held. The patient will need to remain on at least 2 drugs, most commonly the calcineurin inhibitor along with steroids. If they were only on tacrolimus and the mycophenolate to begin with, and the mycophenolate is held, then steroids should be introduced. Regarding steroids, which most centers use, not going to get into the whole list of adverse effects here. Commonly, it is tapered down for maintenance to a relatively low dose of 5 milligrams a day. Now the other 2 drugs, Belatacept and Sirolimus, the mTOR inhibitor, will be only used as a substitute because they're associated with a higher risk of rejection. You need to be concerned about the Epstein-Barr virus and PTLD with the use of Belatacept, although it could be useful if there is a question about adherence with the tacrolimus as it's given intravenously once a month, and if there was any really absolute contraindication to using the calcineurin inhibitor, this could be a reasonable substitute. The Sirolimus mTOR inhibitor sometimes comes into play if the patient has a malignancy as is thought to have an anti-neoplastic effect. In these cases, it may be a replacement for the mycophenolate. It does have some other pretty significant side effects, including impairing wound healing, significant hyperlipidemia, and thrombocytopenia, and has been associated with pneumonitis. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Let me know in the comments below your experience or questions about immunosuppression for kidney transplant. And until next time.